Pneumothorax management. The British Thoracic Society, BTS, published updated guidelines for the management of spontaneous pneumothorax in 2023. The updated guidelines put less emphasis on the size of the pneumothorax and more emphasis on whether the patient is symptomatic and the presence of high-risk characteristics. Now let's talk about the algorithm for management of pneumothorax. The first step is assessing whether the patient is symptomatic or not. So what are symptoms that can be present? The BTS define minimal symptoms as no significant pain or breathlessness and no physiological compromise. In this group, we manage conservatively, regardless of pneumothorax size. But if symptomatic, the next step will be assessing for high-risk characteristics. High-risk characteristics are defined as follows: hemodynamic compromise, suggesting a tension pneumothorax; significant hypoxia, bilateral pneumothorax; underlying lung disease; ages equal or more than 50 years with significant smoking; history of pneumothorax. If no high-risk characteristics are present and it is safe to intervene, then there is a choice of intervention. The intervention may be conservative care, ambulatory device, or needle aspiration. But if high-risk characteristics are present and it is safe to intervene, then we use chest drain. How is safety of intervention determined? Before a needle aspiration or chest drain insertion, the safety of intervention should be assessed. This depends on the clinical context, but is usually 2 centimeters laterally or apically on chest X-ray, or any size on CT scan, which can be safely accessed with radiological support. Now let's talk about management options. Conservative care. Patients with a primary spontaneous pneumothorax that is managed conservatively should be reviewed every 2 to 4 days as an outpatient, while patients with a secondary spontaneous pneumothorax that is managed conservatively should be monitored as an inpatient, but if stable, follow up in the outpatients department in 2 to 4 weeks. Ambulatory care. An example of an ambulatory device is the rocket pleural vent. It includes an 8 French gauge catheter mounted on an 18 gauge needle and a pigtail catheter to minimize the risk of occlusion. Ambulatory devices typically have a one-way valve and vent to prevent air and fluid return to the pleural space while allowing for controlled escape of air and drainage of fluid. Many devices also have an indication diaphragm that signals when the catheter tip enters the pleural space and continues to fluctuate with respiration, aiding in the assessment of pneumothorax resolution. Chest drain insertion. A chest drain should be inserted if needle aspiration of a pneumothorax is unsuccessful. Chest drain insertion requires daily review as an inpatient. You can remove drain when pneumothorax is resolved. Discharge and follow up in the outpatients department in 2 to 4 weeks. Persistent or recurrent pneumothorax. If a patient has a persistent air leak or insufficient lung re-expansion despite chest drain insertion, or the patient has recurrent pneumothoraces, then video-assisted thoracoscopic surgery should be considered to allow for mechanical or chemical pleurodesis, plus or minus bulectomy. Discharge advice. Patients should be advised to avoid smoking to reduce the risk of further episodes. The lifetime risk of developing a pneumothorax in healthy smoking men is around 10% compared with around 0.1% in non-smoking men. Fitness to fly. Absolute contraindication. The CAA Civil Aviation Authority suggests patients may travel 2 weeks after successful drainage if there is no residual air. The British Thoracic Society used to recommend not traveling by air for a period of 6 weeks, but this has now been changed to 1 week post-check X-ray. Scuba diving. The British Thoracic Society guidelines state, diving should be permanently avoided unless the patient has undergone bilateral surgical pleurectomy and has normal lung function and chest CT scan post-operatively. Now, answer the question. A 21-year-old man presents with acute onset left-sided pleuritic chest pain, which has been ongoing for 4 hours. However, since his arrival, the pain has completely resolved. He has no known medical history or regular medication, and there is no recent history of trauma. His respiratory rate is 16 breaths per minute. Heart rate is 75 beats per minute. Blood pressure is 120/64. Oxygen saturation is 99% on room air, and his temperature is 36.5 degrees. A chest X-ray revealed a left-sided apical pneumothorax measuring 2 centimeters from the pleural edge with no mediastinal shift. What management plan should be initiated? Admit and monitor over 24 hours. Chest drain insertion. Continuous positive airway pressure. Discharge with regular ambulatory follow-up. Needle decompression. If you know the right answer, put it in the comments. Thanks for watching. I hope you found this video helpful. If you enjoyed it, don't forget to like, comment, and subscribe for more content. See you in the next video.